I'm Randy Brown. Again, I think I'm familiar with a lot of you, see a lot of familiar names. Again, I'm an associate professor in the Department of Family Medicine and Community Health and director of our Addiction Medicine Fellowship Program. Welcome to another edition of our Addictions Grand Rounds, and really excited about our speaker today. Really important and topical issue these days, and also particular relevance to the populations that we serve that are struggling with substance use, in terms of the disparities in healthcare and disparities of policy and systems. So introducing Hewitt, who's a clinical assistant professor and vice chair of equity and anti-racism in the Department of Psychiatry. She's a licensed clinical psychologist and is involved in research training, which focuses on healthcare interventions, and works with patients and families to optimize well-being by offering them scientifically supported approaches to mental health care. She further specializes in working with women in pre- and postpartum periods and children and families coping with emotion and behavior problems. She does a lot of work with trainees in psychology, as well as in the psychiatry program and with medical students, and does a lot of focusing in that teaching work on implicit bias and cultural humility. Her role as vice chair of equity and anti-racism involves enacting department values around inclusion, diversity, equity, and anti-racism through promotion of equity in healthcare, diversification of the department, specifically education and training in diversity, and advocacy and action regarding individual and community mental health outcomes. So really excited to hear from you, Dr. Hewitt, and take it away.
Thank you so much, Dr. Brown. And thank you all for taking time out of your busy days to join me. Let me start off with a bit more about me and my identities and cultural background, so you know where I am and am not coming from. Academically, I'm a hybrid, trained in research first and then in clinical work. I work primarily as a clinician out of 1102 South Park Street. Personally, I'm a third-generation Scandinavian American. I'm a cisgender woman. I'm a mom. I'm a daily walker and an avid podcast listener. I restore and ride vintage motorcycles, the little tiny ones, not big Harleys. And last year I became a yoga teacher. I also have a non-visible disability. I'm a type 1 diabetic, and I've been diabetic for 43 years. I share this last point because it was an interaction with a physician at UW Health over 20 years ago that's fueled my personal interest and actions related to cultural humility and implicit bias. In this interaction, the provider over at UW Health Endocrinology asked me who I was and said, "Tell me about yourself." And then she said, "What can we do to make diabetes fit into your life?" And for me, that was profound. I had never been asked that question before. In 2 decades, I'd been told what to do, how many times to check my blood sugar, how many carbs to count, what to do, what not to do. And what she did in that question is she embodied cultural humility by first asking me about who I was as a whole person and about my world. And then by offering her medical expertise, what can we do to make diabetes fit into your life? She offered her and her team's medical expertise in an offer to partner with me in my healthcare. Not to sound dramatic, but that changed my life. That combination of cultural humility with medical expertise has shaped my life, and I think has the opportunity to shape many patients' lives. And so what I would like to do today is take the next 45 minutes or so and share with you some of the key components of cultural humility and ways that you can put those pieces and learn about your own implicit biases and put that knowledge and information in conjunction with your medical expertise to partner with your patients to find ways to help them have lives that are worth living, to help increase their well-being, and to help address the medical concerns that they present with. What I will do is share some information with you about cultural humility. And then what I will do is I will pause after that, and then I'll talk a little bit about implicit bias. And then what I will do is I will leave ample time at the end to discuss what I've talked about. I will also take feedback that you give me at the end of today. I'll adjust the presentation to include that. And then what I'll do is I'll send Heather a copy of the presentation so that you have all of the references, all the resources I talk about at your fingertips. So please don't worry about catching them. You'll get the whole presentation when we're done. I also can't see you readily on chat while I'm talking. So if you have questions or I say something like, hey, I didn't catch that, please just give a shout out. All right, so let me get started in terms of cultural humility and implicit bias. First, before we start talking about diversity and equity issues, I want to share some ground rules and tools that I often open up discussions about diversity and equity with. While they're not exactly fitting for today because it will be less of a back and forth dialogue, as we do have some questions and discussions, I'd like to keep these ideas in mind. First and foremost, it's important to understand that everybody sees and experiences the world differently. So what is right in your experience may not be in somebody else's. It is different. We also need to acknowledge that isms exist. Racism, sexism, ageism, ableism exist, and that we're also systematically taught misinformation about our own group and members of other groups. This is true for all of us. We may learn misinformation, we may be taught it, and we don't need to blame ourselves for the information this misinformation we have learned, but we need to accept responsibility for not repeating misinformation after we have learned otherwise. So let me say that again. Once you learn otherwise, if you're curious and interested and learn otherwise, then you don't repeat that misinformation. Respect other people, try to be sensitive to their experiences. Keep in mind that nobody is speaking for all of their aspects of their identity or their culture. Take responsibility when your intention doesn't equal your impact. This is really important. My intention today is to share tools with you to support patient care and to support you as providers. If I say things today that don't impact you in that way with my intention, please call me out. Let me know. You can shoot me an email. And this is a piece of diversity and equity discussions, is that if your intention doesn't equal your impact, help correct it. Keep an open mind as you listen today. So maybe some of your beliefs might be challenged. I'd also encourage you, when I open up today for questions, take risks, engage yourself, ask questions. Remember that we are all equal partners in this. There are no exceptions. With diversity discussions, what I typically say is I like to keep specifics of aspects of ourselves that we may share in these discussions private, but take what you have learned out into the world. Also, if you know that you're somebody who tends to ask 6 questions or 7 questions at the end of every talk, ask one and share the air. Hear what other people are saying. Finally, hold me accountable. If there's something I'm way off on, call me out. Let me know, teach me, help me learn. I am incredibly interested in addiction medicine. I don't have much training in it, and I know it impacts many of my patients' lives. So teach me what your expertise is. And these ground rules and tools, let me just give a shout out. I looked all over for different tools as I lead these discussions, and these come from our colleagues in the physical sciences. Interestingly, it wasn't mental health, or it was actually the folks at NCAR, the National Council for Atmospheric Research, right outside of Boulder, Colorado, who developed these tools for talking about diversity and equity. You can check out the website. They go into more detail, but I found them incredibly helpful. Let's get started talking about cultural humility. First, cultural competency. And I start here because many of us, this is what we are trained in our academic training, be culturally competent. It was first introduced around the 1980s. It appeared in social work and counseling psychology. and then began to spread to education, business, and medicine. And what cultural competency is basically saying we want to have behaviors, attitudes, and policies that come together to help us work effectively in cross-cultural situations. And I will take this moment to highlight for you one of the things the residents have taught me in cultural humility is that when I present, I need to be sensitive to people who may learn in different ways. So throughout my presentation, you'll see citations for original research. You'll see links to web pages. You will also see YouTube videos, and you will see podcasts. So a variety of ways to learn further about the information that I'm presenting. So cultural competency, it's about learning to work with different cultures, so you need to learn about those cultures. Some of the limits with that, though, is that cultural competency is knowledge-based versus attitude-based. It can lead to stereotyping because you can think I've learned a lot about one group and now I know about them. It also ignores power dynamics, but especially in medicine between providers, staff, and patients. And for many people who have patients with multiple identities, it can marginalize them or other them, which isn't particularly helpful. So what do we need? Back in the early 90s, Sue suggested what we need is a more nuanced perspective that focuses on intersecting identities, acknowledgement of multiple influences on our identity in the lives of our patients. And what grew out of cultural competency was cultural humility. Really a relatively new construct, really emerging around the 2010s. Hook in 2013 is where most of us look at cultural humility as originating, and it is the ability to maintain this stance between each other that is focused on the other person, open to them regarding their cultural identity and what's most important to them. And what it does, it focuses on humility instead of a state of knowledge or competency. So it focuses on, I know who I am, and I'm humble, and I'm curious. And that's what cultural humility is. There are three factors that guide that process. And let me emphasize the process of cultural humility. It's a lifelong commitment to self-evaluation and self-critique. It is all about this process. You need to be humble and flexible and look at yourself and learn more. It's very important that our understanding about ourselves is it's only as powerful as the action that follows. And so it's constantly looking at who am I, where are my blind spots, asking about them, learning about them, being curious about them. The second factor that guides the process of cultural humility is a recognition of and challenges of power imbalances. This is really important because what you do, especially in the patient-provider relationship, it is an equal partnership. Your patient is the expert in their own life and their symptoms and their strengths. That vignette I gave you about my provider, she asked me about who I was first and foremost. And then you acknowledge that as the practitioner, you hold a body of knowledge. You hold scientific and clinical expertise that your patient does not hold. And then what you do is you collaborate. You use the synergy between your patient's expertise and your expertise, and you collaborate together, and you constantly address and balance this back and forth. So you recognize these power imbalances and you challenge them, and you come in as two equals, each with different expertise. A third part of cultural humility, a third factor that guides it and that process is institutional accountability. As I mentioned, cultural humility and cultural competency first came out of social work and counseling psychology, and there is a very large social justice and activist component to cultural humility. It says that if you're working to be culturally humble, if you do it alone, you're not going to be able to make much of a difference. But when we partner with people and groups who advocate for others, we can have a profound impact on systems. And so cultural humility is defined as larger than ourselves. We do it individually, and then we partner and we address the larger problems that we're seeing. APA, the American Psychological Association, has a really neat article on this process of cultural humility. So now you may be saying, okay, Ari, I like this idea of cultural humility. It's this process, not an endpoint. It's ongoing. Cultural humility is an action. It's attitude-based versus knowledge-based. It's focused on respect and lack of superiority of partnering with patients. And in that partnering, you don't need to give up your medical expertise. What you do is you also make space for patient expertise about themselves and their symptoms. And you minimize power imbalances when that's possible in the systems that you're in. Right? So that's cultural humility. So you're like, Ari, I like this idea, but how do I do it? You can practice cultural humility at the end of our session today. How do you do it? Principle number 1, the lifelong commitment to self-evaluation and self-critique. Explore your own culture and health. What are your experiences? And I'll talk a bit from a mental health standpoint. What are your experiences with negative and positive emotions? What do you automatically assume if somebody comes in and cries and screams in your office? Or what do you automatically assume if they're quiet and stoic? What are your beliefs about how emotions are expressed? And how does your own health and well-being impact your cultural humility? If you're exhausted, how readily can you hear the other person? I remember stories rather than slides. So I remember the lifelong commitment to self-evaluation and critique and exploring your own culture and health. When I think about one of my mentors in my clinical training, he would evaluate my notes and review them and come back and provide me, probably over the course of a week, more cumulative feedback than I had in any of my English courses in college. He would adjust them. He would say, you can't say they feel a little sad. What's a little? He would come back and question and challenge and ask me lots and lots of questions and say, what about this? Did you think about this? And after about 4 months, I was fairly certain I was going to fail my clinical rotation, that I should probably leave psychology. And I said to him after one of these feedback sessions, I said, I mean, do you think I should continue? I mean, I'm horrible. I seem to not be able to get this. And he looked at me and he said, Ari, do you think my feedback is a moratorium on your competency? If I didn't think you were competent, I wouldn't be taking time to give you feedback. And what I needed to do in practicing cultural humility, and he with I, is that my experience with confrontational and very vivid emotional expression was that it was novel to me. I grew up, as I mentioned, I'm a 3rd generation Scandinavian American. In my family, culturally, if you are going to express upsetness, we might say, how are you doing? And I might say, fine. And that meant really bad. This direct confrontational approach for me registered as something was horrible and awful and wrong. And I made an assumption about his reaction to me. And what I needed to do was explore my own experiences with how emotions were expressed, and then ask and be humble and wonder. And then he could ask with me and we could clarify. And he is one of my beloved mentors. But explore your own culture and health, because if you don't, you may automatically assume things about colleagues and about patients that are untrue. So explore your own culture and health. That's how you practice cultural humility. One way to do that is through a social identity exercise. I'd encourage you guys, you'll get a copy of this. Take this to your clinical groups. Think about the identities you think about most often, that you think about least often. Think about which ones you want to learn more about. Like I mentioned, emotional expression. Think about how different aspects of your culture and your identity, how they affect you and how they affect how other people perceive you. I know that my mentor, after we had the discussion around that feedback, he noted that for him, he learned to tell people, I provide lots of feedback. That is my way of being encouraging rather than telling you you're awful. And so learn about the different aspects of your identity and yourself and how they affect how other people perceive you. Doing this cultural humility exercise, this social identity wheel one, with groups, I found very helpful in increasing compassion for colleagues with each other, because we learn a bit more about the people that we're interacting with. So do some self-exploration. The second principle in cultural humility is a recognition and a challenge of power imbalances. How do you do that? What does it look like? Look at the populations, and Dr. Braun mentioned this, the populations that you're serving and the structural context in which they live. And when you do that, consider people's multiple selves. Consider when they're privileged, when they're subjugated. Consider their strengths and their problem areas and their goals. One of the ways that I remember this is I think about when I went and worked at Journey Mental Health. I was teaching dialectical behavior therapy and mindfulness skills to a group of women, and virtually all the women had pretty significant trauma histories. They were living in poverty, all of them. And I was teaching about mindfulness, and here's an app that you can use, or take a deep breath and practice this visualization. And one of the women I was teaching said, I can't just sit down and notice my body because I have all these flooding in memories of the physical traumas I've experienced. And she said, and if I sit and do something for 10 minutes, I'm going to have a child who lights something on fire. Something is going to break. There's going to be chaos. I don't have 10 minutes. And I paused and I said, well, here's what I know about mindfulness. It's learning to purposefully and under your control, put your attention onto something and then take it off. I wonder, what do you think would work in your life? What do you think is possible? And she came back a week or two later and said, I figured it out. And our group was really excited. And they said, what did you do? She said, I left my phone outside the bathroom when I went to the bathroom. And I just focused on going to the bathroom. And I thought, this woman in her minute or two, a few times a day, was as skillfully practicing mindfulness as many people who've done it for years. When I offered her that culture of humility, I said, who are you? Tell me what's possible. I shared my expertise, not in a way that said, I know exactly what you should do, but I said, here are the constructs I know that guide mindfulness. Tell me what works in your world. Teach me what works. And she taught me, and she has left an indelible imprint on how I think about mindfulness. Consider people's multiple selves. Look at the population that you're serving and the context that they're in. Finally, institutional accountability. So how do you practice that? You develop partnerships with people and groups who advocate for others. You're doing that with me today. You're inviting people in to say, how can we learn more about cultural humility? How do we practice it? How can we do it in the clinical groups that we work with? You talk with your colleagues. You join groups, you take risks. I think about the seminars that I teach when I said, what our students have taught me is they've taught me when they reach out and they say, we need to see changes in our institution, and they partner together. They have said to me, Ari, you need to adjust the diversity curriculum and you need to do it in these ways. They have taught me we have now a living curriculum. Students have said, for groups of students each year, our residents that go through, they come from different backgrounds. And they said to me, Ari, we need to have the curriculum flexible enough to address what each different cohort needs. And so we made it that way. We responded to that. Partner with people who advocate for other people and ask for change. Expect your institutions to make changes. So those are the 3 principles of cultural humility and 3 steps you can do to be able to act in culturally humble ways. There are a number of different resources to help you do this. So you can learn about cultural humility. There's a neat documentary that's on YouTube. Orlando Sanchez did a really neat CEU on cultural competency. You can catch that on YouTube. That's for free. UW Health has an anti-racism website, and they talk about their vision and what aspects of it are in place and what they're working on. They also talk about UW Health, their community health improvement strategy, and what they're doing to partner with different areas or different programs in our area. If you want to learn more about how your culture may impact how you see other people, you can catch the podcast Invisibilia. It talks about implicit bias and what we can do about it, and highlights research that's going on here at UW-Madison. One on depression that I found really interesting was Andrew Solomon. He talks about different cultural views on depression and how depression is expressed. So you can learn. That's that self-exploration and learning. if you're ready to take action, a couple of different opportunities, keys to practicing anti-racism. There's a 30-day challenge. If you want to say, hey, I really want to be an ally and an advocate in terms of social justice around race, you can check that out. That's through Berkeley. Here in Madison, through the Nehemiah organization, they offer a justified anger course, and you can check that out. I have the website there. That's for allies to learn about how they can help to support racial justice across the country and in this area. So here are some resources in terms of cultural humility. I'm going to pause here. Are there any questions that people have about cultural humility? Does it resonate? Does it not resonate? Thoughts?
I have one question.
Sure.
So, do you do workshops for, for situations where there's a lack of cultural humility to instill that?
Yeah.
Where there's like either sexual harassment, and it's or bullying of students or something like that, where within an organization, do you do workshops to kind of facilitate better cultural humility, or how do you?
Really thoughtful. Most of the workshops I do are within the medical system. And so within the medical system, I do a number of them. UW Health also offers them. You can take them, and I'll give those at the resources in terms of implicit bias. UW Health offers in-person resources as well as independent learning. In terms of going out to different community organizations, I have not gone out to do specifically cultural humility with outside organizations, but the Nehemiah organization does quite a bit of that. And some of the different courses at MATC, actually, they've offered some really interesting ones. They brought Ibrahim Kendi in to talk about fostering cultural humility and anti-racism. So I hope that answers it. I do primarily medicine. Other folks do the cultural humility in the area. If you want me to help connect you with resources in the area, I'm more than happy to do that too. Just shoot me a message.
Thank you.
Oh yeah, absolutely. Other questions, or should we head to implicit bias? Okay, I'll head to implicit bias. And you can always shout out questions at the end too. I think we're running right on time. So implicit bias, what is it? And I present implicit bias with cultural humility because part of that self-exploration and ongoing exploration, people often realize that they unconsciously group people into categories. And guess what? It's innate. We all do it. We take information that comes in through our senses and we group it. I look at the tree outside my window and I see a tree. I don't see the different aspects of it. I don't see, okay, looks like it's brown. It's covered in frost today. Looks like it's cracking a bit. We group that input. Everybody does it. Unconscious bias as a term was coined in the mid-90s. And Mazarin and Anthony argued that social behavior is influenced by these unconscious associations and judgments, split-second ones that we make. So we do it, right? What's really important is the groupings that we make, the collections of groupings that we make, those are learned. Those are based on stereotypes and ideas. Those prejudiced ideas and stereotypes, those are learned. Where do we learn them? We learn them in the community. We learn them in the communities that we grow up in, the families we grow up in, the situations we grew up in. Those are one of the biggest areas we learn these different biases. How do we figure out if we have them? Well, you've probably heard about the implicit association test. This is that test where they will flash different words, good, bad, and they'll flash different pictures. They will flash pictures of people of different ethnicities and different backgrounds. And the idea is that if you have an implicit bias, if you have an association, you will more quickly respond to words that match that bias. So if you think peanut butter is fantastic and you see good and you see peanut butter, you'll respond much more fast if it's good in peanut butter than if it's bad in peanut butter. They typically do it with ethnicity. So they'll often show bad, and then they'll show people in minority communities. And if you're faster there, then the belief is that you have a bias, that you link bad with that community. I have listed you the link if you want to take the implicit bias test. I will be upfront, I'm not a fan of it in terms of guiding personal growth because it doesn't reliably predict individual behavior. Why doesn't it predict individual behavior? I will talk about that in a minute and how you can change your implicit biases, how you can shift your biases and not have them go into action. But I do want to point out before I do that, that more broadly, implicit biases are associated with differential care of people in the world. We know that implicit biases are associated with different responses in law enforcement. You can listen to the show from NPR from earlier this year about police shootings and implicit bias. You can also read articles. And I think in addiction medicine, Dr. Brown pointed out that this is fairly common. And you all can educate me much more than I am. When I went and did a review of the literature looking at pain medication and implicit bias, it shows very clearly that in the United States, the pain of Black Americans is underdiagnosed systematically and undertreated compared to the pain of their white counterparts. What was most stunning to me is that when we look across ages, we see that Black patients are less likely to receive pain medication than white patients. When we have kids coming into the emergency department, kids who are presenting for an emergency appendectomy, Black kids are 1/5 as likely to receive opioids for their pain as their white counterparts, even when you control for age, sex, pain intensity, and insurance status. And this is recent. Our implicit biases about who our patients are, how they'll handle pain, how they'll respond to pain, what they'll do with pain, is based on many of our implicit biases, and it shapes how we provide care for people. So what can we do about checking and challenging our implicit biases so we provide the best possible care for our patients? Well, we're not going to change the broader social structures with these implicit bias trainings, but if we can recognize, and I'll talk specifically around race, that racism isn't an individual problem, we first need to act as individuals, and then we need to change the structures that we're in. So I will talk a bit now about what you can do to catch and change your actions based on your biases. Because unconscious bias trainings can help us pause and put under more conscious control some of our behavior. And this is the key to breaking the link between the unconscious bias and stereotypes and prejudices that we may have learned. So what can we do? And I will give props out to Trish Devine and her team in the UW Department of Psychology. She does a lot of trainings on implicit bias. These are taken from some of her work. What can we do to break that prejudice habit? We can replace stereotypes that we have. First, we have to recognize that we have stereotypes and that many of our responses, especially when we're more tired, stressed, or in a hurry, are going to be based on stereotypes. We need to catch ourselves and label our response as stereotypical and reflect on why it occurs. So recognize that we may have stereotypes, catch ourselves, label them when they do occur. I'm responding just because this person came in and they're crying and screaming in my office and I'm going to say they have a personality disorder. Wait, catch it as stereotypical, reflect on why it occurs, and then look at counter stereotypic imaging. Imagine the other person. Why are they coming in that way? What is helping them respond that way? Think of them as individuals. Think of other people who have responded in similar ways. Replace the negative stereotype by thinking about other ways people could have responded, have that look that same way, but be very different than the stereotype you're thinking of. And then take the perspective of the other person. Imagine what it's like to be in their shoes. Do it, think about how they feel, think about what they think about what they're experiencing, think about the systems and the structures around them. What it does is it drops down this automatic biasing. It slows you down. And then make an ongoing commitment to increase contact with people who are different from you. Increase contact so you have many different representations of people who are different from you, who experience the world differently. And I realize I'm saying this in the middle of a pandemic. You're like, oh, that's really funny. Like, I have seen 4 people outside of my bubble. You can do this. Watch YouTube videos, listen to conversations, talk with colleagues. When you see patients, really listen to them, expose yourself to a wide range of people from different perspectives. So those are steps you can take as an individual. As I mentioned, breaking implicit bias and changing stereotypes and prejudice also has to happen on a systemic level. So you as an individual are responsible for challenging your own implicit biases, catching them, challenging them, replacing stereotypes, and seeing people as individuals. With the institutions, what you need to do when you work in a community and at UW Health is don't believe that you're completely objective. You're not. I'm not. Nobody's completely objective. Be open to biases when they may come up. When you do that, you will be less likely to be caught off guard and you'll be able to guard against that. Also, encourage your institution to motivate you to be fair and decrease biased actions. And that may mean that you need to write notes with the patient in the room collaboratively. With many of my patients, I write their clinical note with them when they're there to say, did I capture what you were saying accurately? Does this sound like it summarized where we're at today? Is there anything else I should add? What do you think? So increase in institutions the motivation to be fair, to slow down, and to treat patients as whole people. Also, improve the conditions for decision making. This is related to number 2 quite a bit. What you want to do is not be automatic. Some really interesting work is coming out, and I've talked to UW Health about this, about pop-ups. You know, when you're working in HealthLink, we get the pop-ups. I get them like patient has COVID or patients on a keto diet. If we have pop-ups that are related to areas of medication prescription or therapeutic interventions that are often fraught with a lot of bias, like I did the presentation of an appendectomy, child presenting for an appendectomy in the ED. We know if there's a pop-up that slows us down, it will decrease our bias. So push your institution to improve these conditions around decision-making. Stop being automatic. Think slowly. Take some time before you make the decision. And then 4, count. Be a really good scientist practitioner. Use data to determine whether or not behaviors are leading to disparate outcomes. Look at the patient populations you're serving. What treatments are they getting? What treatments are different patient populations getting? How long are they in care for? What kinds of services are you providing? Ask yourself, be courageous, be fine being uncomfortable. When you can count, then you can challenge outcomes that may be related to bias. So those are different ways you can handle implicit bias. How do you do that? And you're saying, Erin, I need some help doing that. Here are a number of resources. I grouped this time into UW Health, UW-Madison, and School of Medicine and Public Health. I know when I talk, at least in Department of Psychiatry, many folks are jointly employed by UW Health and School of Medicine and Public Health, and some people are employed only at UW Health, and some people only at School of Medicine and Public Health. So I've tried to make resources applicable and helpful for everybody. At UW Health, I want to highlight that they have their diversity, equity, and inclusion website. They also have micro learnings, really interesting. I think there are about 20 of these. They say they take about 30 minutes. I found I read fairly quickly and I go through one in about 15 minutes, and they're really interesting. You can do diversity, equity, and inclusion micro learnings, 15 minutes a day. Start off your day with a micro learning. Really interesting. They're on UConnect. They'll walk you through how to get to them. Also, hold yourself and your colleagues accountable. If there's discriminatory behavior that you notice, or you notice it from patients, you can respond to it using the new UW Health guidelines, and there's a link to it there. There's also employee resource groups. UW Health, I was just told, and it's my understanding, you are paid to attend these groups. So it's not volunteer time. Employee resource groups are for people from typically marginalized communities, and support and resource groups for employees, for UW Health employees. You can go on the UConnect website, and it's right there for you to be able to click on and look at. I believe they have Latinx, LGBTQ, BIPOC groups, and I think there's also one for women in leadership. I may be missing one, but employee resource groups. There are also a number of different services under gender services. So those are UW Health resources that can help you promote institutional accountability and catching bias, help yourself catch your own bias, and practice cultural humility. At UW-Madison, there's the diversity website. Check that out. Ebling Library also offers this really great resource hub. Shout out to librarians for pulling resources together. They've really done an amazing job in terms of their resource hub for events in the community, events at the university that anybody is welcome to. I would also encourage you, UW-Madison does a diversity forum, and the link is there. It's happened this year, but a number of the talks were online. There was an incredibly, I found it moving one on ableism, and it was simply wonderful, and you can get a copy of it there at that link. School of Medicine and Public Health also does weekly emails. I don't know if many of you, if you just see this and you click, yep. This one's really helpful. It's the subject line is In the Know SMPH updates. It comes out weekly. And there's always a link to anti-racism activities that are going on. It will tell you about community events. It will tell you about speakers. It will tell you about book groups. It will tell you about different ways you can. Finally, and a shout out to the Global Health Symposium. That is, I think it's the 14th of April. You can check on that link. Really interesting one this year, connecting scientific knowledge with indigenous wisdom. So a way that you can learn more about how to do that. Their poster sessions, their talks, another way to learn more about different cultures, to practice your cultural humility, and to catch your implicit bias. So let me just summarize. Cultural humility. It's maintaining this interpersonal stance where you're open to somebody else. You really listen to what aspects of their cultural identity are most important to them, and you focus on being humble. You start out with saying exactly what I did today. Here's who I am, and here's who I'm not. Tell me about you. This is a process, not an endpoint. You don't become culturally humble after today. You practice it every single day. It's active and ongoing. Implicit biases, what are they? They're innate. Everybody does it. How we do it and the groupings that we have are learned. You can also shift what happens with your biases by pausing and putting under conscious control your behavior. Last, I implore you, understanding is only as powerful as the action that follows. I thank you incredibly for spending time listening today. I implore you, take action. Set a diversity goal for yourself. Set it for the next week, set it for the next month, set it for the next year, and ask your leadership to have everyone you work with to set a diversity goal. You have SMART goals listed right here. I'm sure you're all like, oh my gosh, I have that handout too. Set a SMART goal. If you're going to tell the patients to do it yourself, but put the understanding that you have about cultural humility and implicit bias, put it into action. If you don't, today will be worth naught. So thank you, and I want to open this up to discussion and questions.
Great. Thanks so much, Dr. Hewitt. Really appreciate your being here and delivering these really important messages for us. kind of across institutions, but in some ways, particularly in healthcare, something, we really should have our eyes to. And I got pulled away by a page, so I apologize if I'm asking a question that's redundant to what you presented, but I'm familiar with a number of people in our audience, and a number are involved in fairly busy outpatient practices and inpatient clinics. And I wonder, kind of in the context of, an initial clinical interaction, if there'd be a couple of pearls or a couple of questions that you think we should ask sort of early on to get, some meaningful sense of a patient's experience sort of along these lines, and how we can address that in this context.
Sure. From a very structured end, and I can include this in the handouts I sent to Heather, you can use a cultural formulation interview with some key stems. So that's on a very structured end. On the end where you're like, I'm seeing a patient at 1, 2, 3, 4, and on the half an hour two quick tips. What brings you in today? What made you set up the appointment? And what would you like out of it? So it's asking people about that. In more depth, rather than going through medical criteria, which we need to go through, like the symptoms of depression, asking people, they say, I feel depressed, then say, help me understand, what is it like for you? How do you experience it in your head, in your body, in your heart, in your spirit, in your relationships? What is it like? And then listen. And then say, why do you think this is happening? What do you think would be most helpful? That's that first part of cultural humility, really exploring yourself, but then being curious about who that other person is. And then you can offer your scientific knowledge. You can say, based on what you've said, here are some interventions I think might be helpful. Let me know, what do you think would best fit with you in your life at this moment? So asking people what brings them in, asking them how they experience the typical symptoms. I can say, do you feel down or depressed most of the day, nearly every day? But a patient may say to me, it feels really tight in my chest, and I don't get that if they say, yeah, I feel down and depressed, right? I have not really learned about them. So I think that's another important piece. And then saying, help me understand, why do you think this is happening and what would work for you? It's like my mindfulness, that vignette I gave about mindfulness. Giving somebody an app isn't going to be great if they have 3 minutes, right? It's not going to be as helpful. So those are just some ideas.
Thanks a lot. I'm watching the chat for questions as well. I see one comment on what you're sharing, indicating that Sarah Hambright really appreciated those questions and how they give the patient empowerment to lead their appointment and health plan. And motivational interviewing skills help. I also see as a comment.
The MI really is a piece of partnering with your patient, letting them take the lead. And I can't emphasize it enough, because I think in medicine we often think, well, if I let the patient lead, then I'm not doing my due diligence and sharing my expertise. You can share your expertise and partner with the patient. I talked with somebody the other day and I said, why don't you give this a try and we'll see what works and what doesn't. If it doesn't work, we'll try something different. Let's see what works best for you and let me know. And then you have to be genuine. I'm really interested to see how this works. Let me know, teach me.
And if others have questions, you can feel free to unmute or put it up in the chat.
Yeah, please. About building trust in the clinical setting.
Thanks, Dr. Hewitt. This is great because it's broad, it's applicable, and it's so heartwarming to see the number of, people that are really passionate about this and want to make changes, in their practice that are meaningful. So thanks for doing this. I wondered if you could speak a little bit to, and you talked about some of the differential care that people get, even in the setting of pain management. That leads to some, frankly, some traumatic or negative experiences sometimes with the healthcare system that start at a very young age. And I think one of the ways to address that is, as you said, cultural humility I think it's also trying to rebuild trust when there are people who may have good reasons for not trusting providers. And people here are all, very well, we all have very good will and intentions. Do you find that, building trust is important, that this is a way of building trust, or is there an aspect to that you could comment on? And if you don't think it's super relevant, we can set it aside.
No, I appreciate that very much. And this is where you'll have to educate me. Part of what I have done when I meet with my patients for the first time is I self-disclose aspects of my identity and share who I am, to tell them where I'm coming from. And then I ask them to tell me about who they are. I make explicit that we are equal partners in their healthcare. And I say, and you are the expert on who you are and what you feel. I will share some ideas and stay kind of up to date on what might be helpful, but tell me what will work for you. And I begin by explicitly laying out my expectation that we're equal partners. And that builds, I think it sets from the very beginning, we're valued. The piece I don't know, and you guys will have to tell me, all my notes are readable by my patients. So I encourage them to read them, to let me know, did I miss something? I have people for whom trust around what is written in a medical record is very challenging for them. And that is how I've come to co-collaborate writing notes. And I'll say, here's what I'm writing. Does this accurately reflect what we talked about? And I have written in my notes, provider, assesses this, patient disagrees and believes, and I leave that in the notes and honor my patient's disagreement. So I co-write notes with them and they collaborate on that. I also will advocate with them if they've had really traumatic experiences. I have found you can use a little patient information note that's a flag at the top of their chart. For my patients who've had really traumatic experiences, they often say patient with PTSD. Talk to them before you touch them. Patient may need a few moments to process treatment plans before they're enacted. And I have them help write that so they feel like they now have a voice and I can be that megaphone for their voice and their partner. I also empower my patients to not work with me. So I say, why don't you test drive me for the next couple of sessions? We'll see if we're a good fit. If we're not, let me know and we can work that feels like a good fit for you. Let's see how this goes. So those are some of the things I do to build trust, offering the ability for patients to say no, helping them co-collaborate on writing notes, and helping let them know I will advocate for them within the system. And I'm also very transparent about what's confidential, what's not, the confidentiality. And I think this is huge, lies with UW Health, not us as an individual provider. And I don't know, you and substance use have some specific confidentiality guidelines that are more stringent than mine, but I'm very clear about that so folks know what they may or may not want to share. Does that answer some? And I'd be open. Do you guys have other things that you use or that you do?
It's amazing.
Yeah, and what happens in substance abuse? Can your patients all read your notes, or how do you collaborate with them around that?
Well, then that depends a lot on the setting, and it varies quite a bit, and can be somewhat unpredictable depending on which clinic you're situated in, or whether you're in the hospital or not. So, there are some departments that are more highly confidential than others, where the default is, patients, for example, not automatically being able to see those notes, but things in our system have definitely been moving more toward that direction. And so I think that's another thing for us to keep in mind. I mean, I think that message, and I really like that around kind of being transparent and sharing in sort of what's being documented, particularly around these sensitive issues is to the good, just in terms of respect for patient, but also, that, right? If the patient has access to notes around sensitive issues and, might be angered, offended, or triggered by something you've written into which they didn't have input, or that they hadn't anticipated you're divulging in the record.
And I can say this calmly. When it happens, I'm like, oh man, I mean, I've had more facepalm moments and I've had like corrections. probably about 30 to 40% of my patients read my notes. I get called on the carpet all the time. I didn't like that. I thought you wrote like this. I didn't appreciate that. So it's challenging to do. But I think that's the courageous piece, is to step in and say, I will partner with you. I am not going to embrace this power differential that I can keep these things private and I can keep my judgments and share them with everybody and not tell you unless it's medically necessary. And there are very few cases when that happens. But I think that partnering really, it's challenging, but it may end up with a much more powerful approach to caring for your patient.
My name's Elizabeth, and I want to thank you. I think you've brought up a lot of really important points. And one of the things that you said just sort of made me think about, and I'm interested to get input from you and anybody else. And when you said that we're equal partners, and I think about sort of in our addiction medicine clinic and the outpatient side, that's not always true, especially in cases where, like yesterday, we had a few patients who really would probably like to have more benzodiazepines, or are not taking the medications prescribed to them, and we're often in a position where we're making really tough choices. And I guess it just made me sort of pause and think about, like, what does that mean in the setting of controlled substances, where there could be risk and we're sharing risk, but people may be in a position where they just really aren't able to hear it, or that may be the case, that there's risk, but they're willing to take that risk. And so I think that it's an important point. I don't have an answer, so I'm interested in others' thoughts on, how that goes. And I think we try to be patient-centered, and we try, to give people voice, but I think there are also times when it starts to feel really risky. And so I'm just interested in hearing your response to that.
I'll share my response, and I'd love to hear how those of you in this field work. My response is that a patient can have a voice and a request and a desire, and I can have a different opinion as a provider, and it makes them no less of an equal partner in their treatment. But there is an acknowledgement of the power that you control the medications and they don't. And if you acknowledge that, you can say you're an equal partner in your symptoms and your experience, and they can make that request. But your expertise is in the medication, and you may say, and medically, I don't feel comfortable prescribing additional benzodiazepines because I feel like this puts your health at risk, and this is why. Are there other ways we can continue to work together? So there can be a partnership, but there can also be limits to your roles in that partnership. How have other folks handled that? Because I think you often have these really challenging discussions.
Well, I think it's got to be patient focused, and I think you can negotiate. So it's like they can say, "Yeah, I want more benzos because I want to sell them, or I want to, I want to trade them for heroin, or whatever the reason." You say, "No, I can't do that." I mean, can we work? Like you said, can we work something out? If they're already abusing benzos, can we kind of work on something to replace that? I mean, so I think it just has to be directed to helping the patient. So I think I put in the comment that it's always a patient focused kind of, what can I do to help you, and how can we work together? And rather than, like you were saying, and I think oftentimes in the clinic, it's this power differential. We come into in to see the patient and say, how's it going? And just, we want quick answers because we're typing on and putting information into the electronic record. And we just want to, and the pressure is we don't have that time to kind of say, let's work on the note together. Let's take the time to kind of do that. And I think it's so much better to kind of have that, kind of build that trust with the patient so that they're engaged in the dialogue. And it is a dialogue rather than a monologue. It's just like, okay. And patients will often tell us the answers that we want to hear rather than kind of telling us the truth.
Yes. I think that may be where we have to wrap it up, that if it's focused on the patient and helping them reach their goals, you may say, I hear you're going down the path of X, Y, or Z. I can support this or I can't support this in my role. And then you can still be partners in saying, I'm trying to help with this. I like this honesty, not perfection in sharing. Ritu says that. So I would like to end by thanking you all again. If you have questions or comments, you can shoot me an email. I will send out this presentation to Heather by the end of the day so you can get copies of it. If you have other things I can do for you, just reach out. And again, thank you so much.
Okay, thanks so much again, Dr.
Thanks.
Hewitt. And
Bye.
next month, we'll be having a presentation by Dr. Majid Afshar, who's in the Department of Pulmonary and Critical Care Medicine here with additional expertise in clinical informatics. And he's been doing a lot of interesting work around the electronic health record and machine learning, natural language processing to come up with some automated ways that we might screen for patients with risky and problem substance use. So I'm really looking forward to hearing more about that work. And he's someone who explains it very well and in clear terms, where it hasn't been complete Greek to me. So don't be intimidated by the content. I'm sure it's going to be great. So thanks all.